Alzheimer's disease, the most common cause of dementia worldwide. A condition that doesn't just erase memories, it dismantles the very architecture of the mind. Today, we will explore exactly how and why this happens, from the molecular level all the way to the clinical signs, symptoms, and management. Let us begin with the healthy brain. The human brain contains over 100 billion neurons, each connected to thousands of others through a vast network of synapses. The hippocampus, a seahorse-shaped structure deep in the temporal lobe, is the brain's primary memory center. The prefrontal cortex handles planning, reasoning, and personality. The temporal lobe processes language and recognition. In health, these regions communicate seamlessly, allowing us to think, remember, speak, and navigate the world. At the heart of this communication is the synapse. When a nerve signal arrives at the presynaptic terminal, vesicles release neurotransmitters, particularly acetylcholine, into the synaptic cleft. These molecules bind to receptors on the postsynaptic neuron, transmitting the signal forward. This process happens trillions of times per second across the brain. In Alzheimer's disease, this elegant system is destroyed by two pathological hallmarks: beta-amyloid plaques and tau neurofibrillary tangles. Let us understand beta-amyloid first. Every neuron produces a protein called amyloid precursor protein, or AP. Normally, AP is cleaved by alpha secretase into harmless fragments. However, in Alzheimer's disease, AP is instead cleaved by beta secretase and gamma secretase, producing a sticky, misfolded fragment called beta-amyloid 42. These fragments aggregate into oligomers, then into larger insoluble plaques that deposit between neurons in the extracellular space. These plaques physically block synaptic transmission, trigger neuroinflammation through microglial activation, and initiate a cascade of neuronal death. The second hallmark is the tau tangle. Inside every healthy neuron, tau proteins stabilize microtubules, the internal transport tracts that carry nutrients, vesicles, and organelles along the axon. In Alzheimer's disease, tau becomes hyperphosphorylated, meaning it gains too many phosphate groups. This causes tau to detach from the microtubules and collapse into twisted paired helical filaments called neurofibrillary tangles. The microtubule tracts disintegrate. Axonal transport fails. The neuron is starved of nutrients and ultimately dies. As neurons die in large numbers, the brain itself begins to shrink. The hippocampus is the first region to atrophy. The cortex thins. The sulci, the grooves of the brain, widen. The ventricles enlarge. In advanced Alzheimer's disease, the brain can lose up to 20% of its volume. This structural devastation is directly reflected in the clinical signs and symptoms. The earliest and most prominent symptom is memory loss. Because the hippocampus is the first region affected, short-term memory is impaired before long-term memory. Patients forget recent events, repeat the same questions, misplace objects, and become lost in familiar places. They may remember events from decades ago with clarity, yet be unable to recall what they had for breakfast. Language and communication deteriorate as plaques and tangles spread to Broca's area and Wernicke's area. Patients develop aphasia, difficulty finding words, naming objects, and constructing sentences. They may substitute incorrect words, speak in incomplete sentences, or eventually lose the ability to communicate altogether. Disorientation and agnosia follow. Patients lose track of time, date, and place. They may not recognize their own home. Prosopagnosia, the inability to recognize familiar faces, including family members, is particularly distressing. Behavioral and psychological symptoms are common and often the most challenging for caregivers. These include agitation, aggression, depression, apathy, and wandering. Sundowning, a phenomenon where confusion and agitation worsen in the late afternoon and evening, is characteristic of Alzheimer's disease and is thought to be related to disruption of the circadian rhythm. The disease progresses through 3 stages. In the mild or early stage, patients experience forgetfulness and mild personality changes but remain largely independent. In the moderate or middle stage, significant memory loss, confusion, and dependence on caregivers become apparent. In the severe or late stage, patients lose the ability to speak, become completely dependent, are bedbound, and develop swallowing difficulties. Death typically results from complications such as aspiration pneumonia or sepsis. The average duration from diagnosis to death is 8 to 10 years. Now let us turn to management. There is currently no cure for Alzheimer's disease. However, pharmacological and non-pharmacological interventions can slow progression and significantly improve quality of life. The first-line pharmacological treatment is the acetylcholinesterase inhibitors, or ACHE inhibitors. In Alzheimer's disease, cholinergic neurons, those that use acetylcholine as their neurotransmitter, are preferentially destroyed. This results in a profound cholinergic deficit. ACHE inhibitors work by blocking the enzyme acetylcholinesterase, which normally breaks down acetylcholine in the synaptic cleft. By inhibiting this enzyme, more acetylcholine remains available to bind to postsynaptic receptors, partially compensating for the cholinergic loss. The three main ACHE inhibitors used are donepezil, rivastigmine, and galantamine. Donepezil is the most widely used, given once daily at 5 to 10 milligrams. Rivastigmine is also available as a transdermal patch, which improves compliance. Galantamine has the additional property of modulating nicotinic acetylcholine receptors, providing a dual mechanism of action. These drugs are used in mild to moderate Alzheimer's disease. For moderate to severe Alzheimer's disease, memantine is added. Memantine is an NMDA receptor antagonist. In Alzheimer's disease, excessive glutamate activity causes overstimulation of NMDA receptors, leading to excessive calcium influx into neurons, a process called excitotoxicity, which damages and kills neurons. Memantine blocks the NMDA receptor channel, reducing this pathological calcium influx and protecting neurons from excitotoxic damage. Memantine can be used alone or in combination with an ACHE inhibitor in moderate to severe disease. Non-pharmacological management is equally important. Cognitive stimulation therapy, structured activities that engage memory, thinking, and problem-solving, has been shown to improve cognition and quality of life. A structured daily routine reduces confusion and anxiety. Safety modifications to the home environment prevent accidents. Caregiver support and education are essential, as the burden on family caregivers is immense. Nutritional support, physical activity, and social engagement all contribute to maintaining function for as long as possible. Alzheimer's disease is a devastating condition, but with early diagnosis, comprehensive pharmacological management, and robust supportive care, patients can maintain dignity and quality of life for many years. Understanding the molecular mechanisms, the plaques, the tangles, the cholinergic deficit, is the foundation of everything we do to help these patients. Knowledge is the first step toward compassion, and compassion is the foundation of excellent care.